Perfect. Thank you so much. So I'm really excited to speak to everyone about today's topic, which is really a journey through a study. So before I talk about the specifics of what goes into a study, I thought I'd just start off by giving you really an overview of the study I'm primarily involved in right now. The reason I want to do this is I want to be a little more personal and directly relate our journey on this thing called amyloid disease with this talk today. So as mentioned, we work specifically on something known as cardiac amyloidosis, and that's just a condition where proteins, they misfold and they accumulate in the heart. And specifically, I work on this protein known as transthyretin, or TTR. And TTR normally exists in circulation. It's secreted by your liver. But due to several reasons, this protein starts to misfold, form these amyloid fibers that can then deposit within various tissues. And being part of the heart center, we're specifically interested in when it deposits within the heart. Okay, so collectively, this condition is known as transthyretin amyloidosis cardiomyopathy. It's quite a mouthful, so I'm just going to refer to it as ATTR going forward. And as you can see, ATTR is associated with many bad conditions. So you can have cardiac manifestations or a cardiomyopathy or muscle weakness. You can have diastolic dysfunction, and you can have heart failure, which is a very significant problem. Also, you can have clinical manifestations such as shortness of breath. You can have increased frailty, diminished quality of life, and then you can have mortality as well. Okay, so at the Heart Center, we actually have several projects and studies revolving around ATTR. So these include several prospective observational studies, which I'll talk about a little bit today. But we also do other things such as biobanking, tissues and blood. We are involved in mechanistic studies to see how amyloidosis develops. And we're also developing novel biomarkers and novel diagnostics for this disease. So how do we get started with ATTR? What went into getting this project off the ground? What does it look like day to day? And how can we translate and disseminate the study? So broadly, any study can be really divided into three major phases. Okay, so you have your pre-launch phase, which is all the things that need to be done prior to approaching your first patient. So this includes things like conceiving of the original idea and further refinement of that idea. Next, as shown here, money obviously is a very important part of the project. So how will you get money to actually perform your study and complete your study? And finally, you need to get the necessary staff and study documents in place prior to approaching your first patient. Next, you have the study launch. So this can be post-launch or the active phase of your study. So this includes very basic things that many of you are familiar with, so day-to-day operations, any administrative activities that you need to do, as well as tracking performance indicators for KPIs. And finally, you have closing of the study. So this involves actually closing your study and reporting to your various different people. And then you can have dissemination of your study as well as knowledge translation. Of course, these aren't very isolated steps. For example, unless you have a very big grant right off the bat, it's often the case in these large multi-year studies that you'll need to reapply for funding. Training study documents, they happen throughout the trial. Many administrative activities also happen in the pre-launch phase, and you never just wait to disseminate and translate your knowledge to the end of the study. You often do that throughout the study itself. But for the sake of clarity, I just thought I'd separate it out this way. And as mentioned, given that short background, all of this will be discussed in the context of our amyloid study. So the most important question or part of your study actually occurs before you recruit your first patient, and that is developing a good research question and honing that research question to form the basis of your study. Really, the timeline varies from study to study, but usually it happens at least 12 to 18 months before you actually begin to recruit participants for your study. So often it takes place quite a long while before you actually begin. So what do you need in order to develop a good research question? Obviously, some things seem very intuitive. You need a command of the literature. So you need to know what other people have done to avoid just repeating what other people have done. And you need to develop a novel project. And you should know who the major players are in the field. Okay. From here, only by understanding what's in the literature can you identify a gap in the field that your study can and will address. Okay, you need expertise. If you're a little bit more of a senior person like myself, you are considered the expert, and you will be responsible for driving this research question a lot. And you also need a support network. So you usually never do a study by yourself, but you develop and hone and craft a team that can complement you in areas that you can't do yourself. For example, I work on cardiac disorders. As a non-MD, there's only so much I know about clinical cardiology. And so we need to rely on actual cardiologists, actual MDs, cardiac surgeons, in order to form our team and provide expertise for me. And then finally, you have infrastructure, right? So you need to have a necessary team in place, office space, or if you're doing experiments, you need to have equipment to support those experiments. And while it might seem like a good initial idea, it always results as you're honing this research question, you always have refinement and further development of the ideas at this stage. So if you're wondering, where can I have input? Really, the input at this stage in developing a research question depends on where you are in your training. So for example, if you look at this graphic and you have a professor or a principal investigator, these are the individuals that will most likely be responsible for creating your study and honing your study. Okay, if you're someone like myself, I'm not quite at the level of a principal investigator. I'm more at a postdoc scientist level. So I guess this team over here, while I'm not solely responsible for the study, I'm at a stage right now where I have a lot of input and I actually develop my own research questions as part of our own ATTR program. If you're a trainee, so if you're a master's or a PhD student, really your input would vary depending on where you are in your training. So when I was a starting master's student or a starting PhD, usually an idea was already developed. But then as I trained and trained further, and then I was a third or fourth year PhD student, I actually had input at this stage. And finally, if you're an undergrad, it's a little bit rude, this drawing to show you guys as babies. That's not true, but really, it's really unfair to expect an undergraduate to develop their own research question, right? You're at this stage to actually develop more skills. And so a lot of things are handed to you, and if you're comfortable, you can suggest ideas. And we typically like to hear ideas from anyone. So in our case, really the original concept for the ATTR study came from a clinical cardiologist with interest in ATTR. So in this email that we got in January of 2021, we got this fateful email that said, hey, there's a potential for a Canadian research opportunity in ATTR. And this cardiologist said, I would be interested in doing XYZ. What are your thoughts? And I need help really to run the study because I'm a cardiologist, I'm focused on caring for patients, and I need a team of individuals to help me collect data, coordinate the study, and everything like that. So the first thing I thought was, what is this disease that we're talking about? I actually had no idea what ATTR actually was when the email came, because this is originally what we thought as a really obscure disease. Okay, so looking at the requirements or needs that you have to develop a good question, if I take a look at myself, did I have a command of the literature? Definitely not initially, but after a month of some pretty intensive reading and research, yes. And right now I do consider myself to be an expert in ATTR. Okay, from this, do we have a gap? And the answer was a resounding yes. And that's what made me really push to start this project. So some of the things that we don't know about ATTR is that the prevalence is unknown in Canada. So how often this disease is seen in our cardiac care population is unknown in Canada. What about diagnostic delays? They're very common, and often a patient has to wait for 6 years in order to get a diagnosis for ATTR. And in many cases, misdiagnosis often occurs. So 30 to 50% of patients with the disease are misdiagnosed as something else. We have at-risk populations, and one we decide to focus on for our initial clinical study. And outcomes are unclear. So if someone has ATTR and they have a concomitant disease. Do they do worse? We didn't know. There was some evidence, but not clear evidence from Canada. What about expertise? So as I mentioned, initially I wasn't an expert, but now I feel like I am. But we did have a clinical cardiologist with national recognition and expertise in ATTR. Okay, so he was our primary point person in order to start developing a research question with. But more broadly, I, as part of a research team at the New Brunswick Heart Center, we have very broad expertise in running clinical studies. So we believe that with our expert in ATTR, we could actually develop a good research question around this disease. And finally, infrastructure. Yes, that was also a selling point for us. In New Brunswick, there's only one tertiary cardiac care center for the entire province. So if anyone needs surgery, they come to our center. Okay, so it was positives in some aspects in terms of infrastructure, but no in other aspects. For example, there was no screening algorithm, no process for diagnosing ATTR, so we actually had to come up with a lot of that ourselves. So what about the next question? So now you think you have a good research question, but the big question is do others? Do others believe in your study, and will they give you money to perform the study? Okay, so is your project fundable is a really key question as well. Now this process takes place anywhere from 6 to 15 months before your study actually begins. And we know that there are actually many avenues in which you can apply for funding. These include those from competitive, where you are competing against other researchers, and non-competitive avenues, where they kind of just give you the money. Okay, this includes very common places such as the Tri-Council, so CIHR, NSERC, and SSHRC for social sciences. Then you can also have local agencies that provide funding for research studies. In particular, we have one known as Research NB, formerly known as the NBHRF, that is very positive, and they're very supportive of funding different clinical studies. You can have industry partners or sponsors. I will get into one that funded our study in the next slide. And then finally, you have charities, foundations, and nonprofits, things like the Heart and Stroke Foundation for us, or the MITAC. So I'm a MITAC scholar, so they provided funding for me to do this. What do you need all this funding for? It seems very intuitive, but we just don't run on volunteers. So about 60 to 70% of any grant I write, it's used to actually support our staff. So those clinical coordinators, research associates, database managers, all of this is used, the funding is used to support them. Up to 30% of a grant is spent towards day-to-day operations, and up to 10% or whatever's left over is spent on knowledge mobilization activities. So we have some funding usually from each grant to send someone for a conference to present the results. Okay. Once again, in our case, we initially applied to Pfizer. Pfizer had an open competition for ATTR research. And the reason why Pfizer was interested in providing money is that they actually have a therapy for ATTR. So there's a very significant incentive for them to fund any research in ATTR, right? If we identify more ATTR patients, they're able to treat more patients, and it's a win-win scenario. So this grant was actually due on March 31st. So only about 2 months after that initial email from our clinical cardiologist. So in 2 months, I had to become an expert in ATTR, and I also had to actually write a 15-page grant, developing an idea and a project around this. And in June, so only 3 months later, we learned that we were successful. So we were very happy. The question is, did we get a check right away? Did we start throwing cash around? No. I'm going to take that out because it's annoying me. But really, we have to open up accounts at the Horizon Health Network or at Dalhousie University, depending on the site in which the study will take place. And then Pfizer sends a check, and we open up the accounts, and now we have access to funding. So in our case, the accounts were only opened in October of 2022. It might seem like a long time, but this process was actually relatively quick. In some cases, we have to wait 6 or 8 months for funding to arrive and accounts to be set up at our site. So that can cause a really significant delay in starting your research. Now from there, from that initial grant, we were actually able to leverage that grant with many of our provincial granting agencies. So working with places like, Research NB, the Heart and Stroke Foundation, MyTax, we were able to essentially develop a war chest to support our clinical study, right? And you often need to leverage and amplify your initial grant, because one grant by itself is usually not enough to run a whole study, especially if it's a multi-year study, right? Now, you have funding, that's great, but there's still a lot of planning that really needs to occur to gear up for your study. So this usually happens in the month to 6 months preceding the launch of your study. So you need to have many things in order to start your study, right? So you need to have a research team. If you write a grant to hire someone new, you have to hire that person and ensure that they're in New Brunswick, they're available to start recruiting patients, and they have all the necessary training, right? You need to have, you could, and we suggest that you register your study. So registering your study on clinicaltrials.gov, for example. Most important, you need something called a trial master file. So this is a collection of documents that could be used to really independently monitor or audit your study to demonstrate that you're complying with GCP, so good clinical practices, and the protocol as well. So this includes many things if applicable. So delegation logs, so who's responsible for what. Often if you have 10 or 15 people involved in your study, you need to have very clear defined roles for each of these individuals. You obviously need a clear research protocol. So what are you doing needs to be spelled out very explicitly in your protocol. Because we're in a bilingual province, you need to have documents in both English and French if they're going to be put in front of a participant, okay? So you do need your informed consent documents in English and French. You need case report forms. So if you're doing something like biobanking, which we're doing, or if you're administering questionnaires, you need to have these forms in your trial master file. Other things like enrollment logs, investigators, brochures still need to be within your trial master file. Okay. If, for example, you are part of a study site, you could also have something called a monitoring plan, where someone from the main study site can actually come to your site and look through all your documents and independently see that you're doing everything as spelled out at the original protocol. Ethics approval. This is a must, and this is required for any clinical study. Here at the Horizon Health Network, we actually have two places, so the HRPP and REB. So HRPP is the Human Research Protection Program. So this is a pre-research and ethics board process that ensures that the rights of the participants are protected in your research protocol. And then we have a research and ethics board, right? So you need to have this in place for you to commence your study, and often for Pfizer to release a check, they require all of these things to be in place. Now, I do have something else, the UCLA. So in the past, as a PhD student, I used to work with preclinical models. So I used to work with rodents. Just because you're not working with humans doesn't mean that you don't need ethics. So if you work with mice, as I did, you needed to submit documents to the UCLA. So the University Committee of Laboratory Animals, and this is really the same thing, that you're doing your experiments and research ethically. And there's, I believe, another committee for invertebrates. So if you're working with worms or something like that, there is a process for that as well, okay? Luckily at Horizon, a lot of these templates are spelled out for you. So rather than developing a research protocol from scratch, you usually have to cut and paste, I find, in these. So they're very helpful for speeding up the process. And finally, I said you need access. So if you're ready to start your consenting, you're ready to approach your first patient, but the door that you need to go through is locked, obviously that's a problem. So you have to ensure that you have access to wherever you need to go to actually consent the patients. Okay, so all of that's done and you're finally here. So now what? from our inception, so from that email in January of 2021, our study actually finally launched last year in March. So 14 months after we conceived the idea. And interestingly, this was still a period where COVID restrictions were in place. So we had to deal with that a little bit. Okay, so in general, when we launch a new study, it's always important for us to actually start slow. So rather than recruit as many patients as possible, we find it actually best to start with only 1 or 2 patients. So this is what you do really at the beginning of the study. And why do we do this? We want to ensure that all the SOPs, so standard operating protocols, are followed. And it's a really great opportunity to identify any gaps in your study, any issues with communication with participants and research staff, and to identify and deal with any mistakes that you could run into. And once again, you can always feedback with the team, right? So if I write something on paper, did I write something in a logical way? If we have feedback from the team or individuals that are on the ground and interacting with the patients, that's always good for us to know. Now, one of the questions that was asked was, what are some of the biggest obstacles studies usually encounter? So one of them is no matter how much you prepare, if you're launching a new study, and it's not the same thing over and over again, really we find out that there are certain obstacles or issues that pop up. And that's why it's always good to start with 1 or 2 patients, so you can work around these issues or obstacles with only 1 or 2 participants rather than 10 participants. Okay, if you recruit a bunch of patients and then you find out that you did something wrong and you need to submit an amendment or something like that, in some cases, if it's serious, you need to reconsent those patients. So it's much easier to reconsent 1 or 2 patients rather than reconsent 20, for example. Okay, so you've worked out any kinks at the start of your study, and now you get into a groove and you settled in for day-to-day operations. So for our ATTR study, actually most time will be spent in this phase. So we have a 4-year recruitment period from 2022 to 2026 in order to reach our study goals. So many activities really fall under day-to-day operations, but this includes things like identification of eligible participants. Okay, and there are many different mediums in which this can occur. So for our study, since we're recruiting and screening patients for ATTR in a surgical population, we can actually identify patients through operating room schedules. We can look at surgical wait lists, and sometimes we can identify patients from the CCU or ICU, so the cardiac care unit or the intensive care unit. We need to approach patients and consent participants to our study. Okay, so we can do this through mail, phone calls, and in person. And we usually wait a little bit of time from that initial point of contact to our actual consent discussion to give patients or participants enough time to read through and understand the study. Okay, we need to create and maintain patient files that contain all the necessary documents. Okay, we need to abstract data. We need to input that data somewhere, and we need to ensure that we can audit or validate the integrity of data. Okay, so once again, for our case, we need to abstract risk factors for ATTR. So we pull out key variables from echocardiography reports, patient history, biomarkers, and EKG parameters. Okay, and as well as results from CT scans. Okay, and finally, reports are also a key part of day-to-day operations. You're likely not reporting, writing reports every day, but in a month, maybe you'll write about 3 to 4 reports. These are reports to the sponsor if your study is sponsored, grant updates if it's funded through a grant. We need to submit amendments, annual study renewals, protocol deviations, et cetera, et cetera. So there's a lot to do day to day. So another important thing is actually tracking and measuring progress, or KPIs, or key performance indicators, right? So we track many aspects of our study, including, for example, the number of eligible patients. So how many patients actually fit our eligibility criteria? How many of those patients were actually approached? How many were consented? How many, after our consent discussion, decided to decline and not participate in our study? how many initially consented to our study, but then withdrew from the study and we had to remove them from the study, and how many of them completed protocol specified requirements. Okay, so we track many of these aspects. Here's really a very simple graph that we use to track how many patients are active within our ATTR study. So in a year and a little bit, a year and a half of recruiting, we've actually consented, or we have about 30% of the necessary number of patients for our study, right? However, if we look at those that have actually completed our protocol specified requirements, that's at 17%. So right now we are on track to complete by the end of 2026, okay? But that could change. Okay, so KPIs are important, so they demonstrate to whoever we need to, the principal investigator, the sponsor, whatever, that we are on track to complete the study in the time specified. It's also very helpful for monitoring or oversight purposes. Once again, we run into more obstacles here, right? There are sometimes missed opportunities, right? So if we have 30 eligible patients, but somehow we only approach 20, that means that we've missed the opportunity to consent 10 patients, okay? And it can happen for a variety of reasons. For example, you can have staff turnover, someone leaves for a different job, right? And so you have a little bit of a gap in which patients may not be approached and consented. You can have staff coverage issues. So someone goes on vacation and we try and overcome that by cross-training individuals and having round-the-clock staff coverage, okay? You can have a lack of training. We try to avoid that by making sure that our coordinators and our associates are trained properly to be able to consent and approach patients. And something very simple like not being bilingual. So if you don't speak French, you could actually miss the opportunity to consent people who do speak French, okay? One of the key problems, this is true for any trial, is dropouts. So if you have someone that has actually consented to your study, but they withdraw or they drop out, they don't complete protocol specified requirement, that's actually a huge investment on your time for someone that actually doesn't complete the study, okay? So in some cases, your dropout rate could reach as high as 30%. I think for our study, we're at around 15 to 20%. 2 questions were asked on how do we actually reduce the rate of dropouts. In many cases, I find that patients, there's still a little bit of a communication error. So no matter how well you think you're actually speaking to the patient and consenting them and explaining the study to them, there still might be a gap in barrier between communicating between yourself and the participant, okay? A very recent example, so part of our protocol for our ATTR study is that patients require a CT scan, and they require injection of a radio tracer to look at the presence of amyloid in the heart. So what we were finding out is that many patients were actually consenting to the study, but later on, they found out that they didn't want to do a CT scan. They were afraid of radio tracers. Some patients were actually claustrophobic of the machine. So we were finding out that a large number of patients were actually initially consenting, but because they didn't understand the process, they were dropping out. So to avoid this, Dana actually created a very nice, easy to visualize graphic that we now give to patients before our consent discussion or during our consent discussion so they understand all risks. Unfortunately, regardless of how well you prepare, a certain number of patients will drop out. In our case, we're dealing with a very sick population, right? So we are dealing with patients that do require cardiac surgery. In some cases, they require cardiac surgery urgently, right? So they might be too sick to actually understand what they're consenting to. They might be too nervous. You know, patients might have one disease and they're afraid of actually being diagnosed with another disease, so ATTR in our case. So it's understandable as long as you're empathetic to patients and really your communication is clear. You can avoid high rates of dropout, but you can never completely eliminate it. And then finally, there are actually wrenches that are sometimes thrown your way. For example, had an example. One of the recent wrenches we had to deal with was the fact that One of our 4 sites in which patients get a CT scan, they don't have enough staff. So they only do those CT scans urgently, and our study doesn't fit the criteria. So we really just have to wait it out and hope that this site can actually start doing the necessary CT scans again. And I always like the scene. So someone might throw a wrench at you, or a wrench might be thrown at your study, but you just got to learn how to deal with it or avoid getting hit by the wrench. This is from Dodgeball. Now, there are many times where you're very busy dealing with your study, and one of the questions that was asked was how to get motivated during the downtime of the study. So there are really a few points that I like to integrate myself as a researcher. So first, during my downtimes, I try and chip away at medium and long-term goals. In my case, this usually takes the form of writing, right? So writing grants, ensuring that there's salary for everyone, that we can continue operations, or writing publications. So at any one point, I could be working on 2 to 3 grants and as many publications. So whenever I have time, I'm not teaching, I'm not actively within the study, I try and get some writing done. What's even greater, mainly for trainees, is this idea of credentialing, right? So this is a concept that was brought up in previous sessions. This is a way to increase your skill set in your CV, right? So it really looks good on your resume or CV, and it helps you negotiate a higher salary if you need to, and it makes you more marketable if you're ever looking to leave your position, right? So there are many avenues here. There's free and paid training sessions, and in fact, in part, through the My Road initiative, has many links and resources available to individuals for training. Okay, Coursera is a good site, so you can audit these courses for free, or you can pay a nominal fee of about $60 to get a certificate. And finally, your institution has many resources that can be used for you to train on. Okay, and sometimes costs might be an issue, but I say it never hurts to ask if your institute, your PI, can actually cover some of these costs. And in many cases, we actually do for our trainees. Certifications, very important. So if you want professional certifications, if you're a coordinator, for example, something like SOCRA, so Society of Clinical Research Associates, is good as a professional designation. So PMP, so Professional Management Professional, or Program Management Professional, that's another designation that is very good to have. I've actually recently undertaken training to write systematic reviews, right? So this was a certification that I now have that I can actually review and write systematic reviews, which is an important skill set to add on my CV as well. One thing that's not appreciated, bilingualism, so learning French really opens up a lot of doors, especially if you're in a French-speaking area like New Brunswick, right? So we have a French cafe that you can take if you want to start learning how to speak French, but that's also available to you. Now, it's all not work, so please take time to relax. We try and do this in a few different ways. So we celebrate milestones. So if if you recruit a certain number of patients, we try and celebrate with treats. We've actually just recently started that. And I always find it's good to take a breather. You don't have to be working at all times. It's good to take a breather to prevent burnout and reduce stress. Okay. Part of the problem with me sitting at my desk a lot is that I tend to lose focus. So just me getting up, going outside, enjoying the sunshine really does wonders for me, and it increases productivity. Okay. Now, we're not quite here with the ATTR study, but eventually we'll reach the end and we'll actually close the study. Okay, so at the end of the study, all study activities are recorded. All participants have completed protocol specified requirements. Everything is reported and we are in compliance. Okay, so here we hit the targets. Patients have completed everything, all data is collected, and everything is ready for statistical analysis. While a majority of studies do close out and reach the necessary number of requirements, in some cases, we actually need to terminate the study early. So that happens in about 10 to 15% of cases. This isn't a reflection on a failure of the study. But it could be that you don't have enough funding or personnel to continue the study. If you're a study site, your sponsor may request that you actually close the study. For certain early phase clinical trials, there could be an issue with toxicity or efficacy, or you can have insufficient recruitment. Okay, here there's really a flurry of activities and documentation that needs to happen. You can have a closeout visit by a sponsor or a monitor to shut down the study site. You can close your study with the RAB. You can archive records. This will vary what you do, but you could move all of these documents offsite. You could de-identify them. You can move them in a secure location. And it varies as to how long you're supposed to keep these files, but it could be 25 years or longer. Okay, and then finally, once again, if you're funded by a grant, you actually need to close the study through your granting agency. Okay, in our case, our clinical study is expected to close in March of 2027, so quite a ways down the road. In the last 2 or so minutes, I just want to talk about dissemination and KT. Okay, so of course, as I mentioned, dissemination occurs throughout the entirety of the study, but here is some finality here. Okay, so there are many mediums that you can use for dissemination. So traditional ones include peer-reviewed studies. You submit to a journal, undergo reviews, and then it's published, right? You can write a review, or you can attend conferences and give an oral or poster presentation. Okay. Non-traditional mediums actually also form a key part of this. So these include websites such as Impart. Impart does a good job of highlighting successes or highlighting activities. You can do interviews, socials such as Twitter, Facebook, and Instagram, podcasts, and presenting at various rounds. So like the New Brunswick Heart Center has weekly rounds in which someone will talk about a topic. Okay, so as I mentioned, Impart actually helps a lot with dissemination activities on this front. And another question that was asked is, what are some tips for selling or highlighting aspects of your study? Okay, here's some general advice. First, know your audience. What I do is I actually like to tailor my dissemination strategy or packages based on the audience. Okay, so you would communicate differently if you're dealing with a lay audience or the public or government versus dealing with experts. Okay, so if I talk to someone at Pfizer who works on ATTR, we can have a high-level discussion. I don't need to explain to them what ATTR is, and we can use more technical language. But if I'm talking to a lay audience, here I need to actually simplify things a little further and highlight gaps and how my study will impact various things. Okay, with that, develop and create an elevator pitch. So can you explain your research or what you do and why it's important in 30 seconds to a minute, right? So those 3-minute theses are very important for this. But can you create one for your study that can talk about dissemination, talk about why you're doing the study, overall results? Okay. Third, really this is critical, develop high quality visuals. Okay. This is an easy way to make things interesting and eye-catching as possible. And you can actually develop these high quality visuals by developing graphics through credentialing once again. So we use something called BioRender, but also, for example, using Adobe Photoshop. So for example, for our study, we have multiple graphics that's used typically for grant applications or from presentations. And we have had a lot of positive feedback from sponsors, from Pfizer, from different grants that they love our graphics. So this is an easy way in which you can score points with your audience, right? Rather than writing something over a page, if you can show it in a graphic, that's very helpful. And then finally, get to the point. For grants, we usually highlight the gap, how we're going to address the gap, and the impact in the first paragraph of a grant. We don't need to write a whole page to get to the point. And often I find that people, they take a lot of time to get to the point, whereas someone doesn't want to read or slog through a whole introduction before they know what you're trying to do. They want to know right away and whether you're qualified to actually execute on this. And finally, the final slide has to do with knowledge translation. So how can we translate the knowledge of the clinical trial into practice? So we know that a vast majority of research results don't end up in the clinic. And so I think really multiple aspects can be integrated into practice. As I mentioned in the previous slide, make sure you create a dissemination strategy, and whether you're working with the lay audience versus an expert. Once again, tools and graphics are your friend, and they can be used for your study as well as the broader community. And that's what we think will happen for our ATTR study. So we developed a screening tool, a screening algorithm that will be used by clinicians in New Brunswick to screen patients for ATTR. Okay. Small studies can impact locally, and you can implement changes right away within a local center to impact and improve patient outcomes. And if you're dealing with a larger study, you can actually change guidelines. But really don't discount the work of smaller studies, because if they can be collated within something like a systematic review, then they can be used to drive best practices. Unfortunately, you do need to deal with some barriers. For example, if you have a study that challenges current practices, there'll always be some barriers or resistance to implementing them. Users are often resistant to change. So do you want to tell a cardiologist that they need to change how they screen patients, and they need to change what they've been doing for 20 years? Obviously, there's going to be some resistance here. And make sure you perform high quality research so individuals will trust your results. Okay, with that being said, I am done, so I can take any questions if there are any. Thank you.
Perfect. Thank you so much, Ken. That was a really great overall journey of a study, and there's a lot that goes into it too, like you say, in the day-to-day aspects that go into a study. Do we have any questions at all? And I'm positive all the questions that I was going through the list that were asked, they were all answered. Does anybody here have any questions for Ken? No? Okay. Oh, Lolita, you have a question? Go ahead.
Thank you for the presentation, Ken. I have one question for you. In a situation where a study, let's say, has run its course, it's done its KT and everything, but there is need for implementation, and it's not like, have you had studies that do not always get implemented after you've done the whole thing?
Yes, and actually, I think we're dealing with that issue right now. As I mentioned, there are barriers to every study. So, having results that challenge the current practice, it's really difficult to get clinicians and individuals to up these practices. In some cases, what I maybe I'm just my sorry, I'm getting some feedback. Maybe in some cases, you need to reiterate these points again, and perhaps in some cases you need to start small. So don't change the wheel right off the bat, and don't suggest, don't have a list of 20 changes that a clinician has to implement in order to, agree with your study. Usually, if you start small, you might get the ball rolling, and then as you go on, and it's shown to improve patient outcomes, then there'll be a bit more acceptance of any changes that you have. But there's a whole branch that also deals with implementation science, so that also is an important part of KT and knowledge mobilization.
Okay. Thank you.
Thanks.
Perfect. Any other questions from anybody? Okay, perfect. With that, we're all done. Thank you so much, Ken, again, and I hope you guys have a great evening.
Thank you.
Thanks.